Okay, so I did my diagnostic testing project on the liver panel in pregnancy. Start with a brief introduction. Liver diseases in pregnancy encompass a diverse range of problems. Some of these are unique and specific to pregnancy and occur only during pregnancy, and others may be exacerbated by pregnancy, may be a pre-existing underlying condition. Knowledge of the spectrum of liver diseases in pregnancy is important because some of these require emergency management. Not all changes to the liver during pregnancy are pathologic, so understanding how certain parts of the liver panel test increase and decrease during pregnancy that can be considered normal is important to be able to rule out or understand whether or not there's an actual problem. What is the test? A liver or hepatic function panel test is a blood test to assess how well the liver is working. It measures blood levels of total protein, albumin, bilirubin, and various liver enzymes. High and low levels can mean liver damage or disease, but it's important to note that there's no single liver function test that is available that actually quantifies a liver disease. The hepatic function panel that we run at the birth center is typically a 7-part test. I pulled this from LabCorp, which is a lab that we commonly work with. It tests for protein, serum albumin, direct bilirubin, total bilirubin, alkaline phosphatase or ALP, aspartate aminotransferase or AST, and alanine aminotransferase or ALT. And these are normal lab values for each of those tests on the panel per LabCorp. How is this test performed? It's performed by venipuncture using a gel barrier or a tiger top tube that's centrifuged to separate serum and plasma within 45 minutes of collection and submitted within 2 days. This test is not routinely performed prenatal laboratory test, so there's no specific time that it's performed. It's based on symptomatology to rule out typically cholestasis of pregnancy, but there are other disorders that might cause suspicion and warrant a need for one of these tests to be performed. But typically in the case of preeclampsia or HELLP syndrome, other metabolic panels or a complete metabolic panel is run, or other adjunct tests to, kind of specifically get to what's going on. Some of the symptoms that might warrant a liver function panel would include sudden onset of acute right upper quadrant pain, epigastric pain or costovertebral angle tenderness, jaundice. Symptoms of cholestasis include pruritus, which is the itching, in the 3rd trimester typically, but can begin as early as the 1st. Pathognomonic of cholestasis is the itching of the palms and the soles of the feet, steatorrhea, nausea, and vomiting. And then symptoms of acute fatty liver disease would be a picture of anorexia, nausea, vomiting, malaise and fatigue, headache, and abdominal pain. On physical examination, the patient is usually febrile and jaundiced. So in any of these cases, you might want to run a liver panel or liver function test. Because of hemodilution and other normal physiologic changes in pregnancy, again, it's important to recognize some of the normal changes that happen with these labs during pregnancy, because a lot of the labs, well, LabCorp and Quest specifically, don't differentiate their labs based on pregnancy. So there's no specific normal values to pregnancy, so understanding that some of these values being elevated or decreased and are considered normal are important to be able to rule out disorders. So in this case, serum total and free bilirubin concentrations are usually lower in pregnant women than non-pregnant in all 3 trimesters, as are concentrations of conjugated bilirubin during the 2nd and 3rd trimesters. There's a normal decrease of albumin in the 1st, 2nd, and 3rd trimesters. Serum alkaline phosphatase activity increases late in pregnancy due to the function of the placenta. And serum aminotransferase levels or ALT levels are typically the same as non-pregnant, but that specific test usually remains the best for routine diagnosis of liver disease during pregnancy. Some of the possible diseases that can occur that are specific to pregnancy with regards to the liver are hyperemesis gravidarum. Believe it or not, 50% of patients with HG will have liver disease. Acute fatty liver of pregnancy is an uncommon but potentially fatal complication that usually occurs in the 3rd trimester or early postpartum period. Intrahepatic cholestasis of pregnancy, which I kind of already talked about with the pruritus that begins in the palms and soles, extending eventually into the legs and abdomen, and presents with also an adjunct test would be elevated serum bile salts. And hemolysis and elevated liver enzymes and low platelets, or HELLP syndrome, which is a variation of preeclampsia that would also present with elevated, with an abnormal liver panel. I included this because I just really liked the picture that has all the information of ICP. And then we get to just some additional notes that I wanted to point out. Liver disease such as acute viral hepatitis can occur in pregnancy, and pregnancy may occur in a patient obviously with a chronic liver disease, including patients with cirrhosis and portal hypertension, meaning that's something they already have when they get pregnant, and patients who've undergone liver transplantation can also get pregnant. It's important to note that in an effort to rule out certain liver diseases, other adjunct laboratory tests like I talked about before, such as bile acid salts, platelet counts, GTT tests, and other metabolic tests can help further create a picture of what's actually going on and point you in the right direction. It's also important to note that most liver function tests detected on automated panels do not truly evaluate one specific hepatic function. Even those that qualify as such do not do so partially, since other factors may influence their serum concentrations. So, like I pointed out before, it's important to know what normal levels are during pregnancy and what normally elevates and decreases during pregnancy for management of liver diseases. With regards to midwifery care, if the specific components of a panel are considered abnormal, what we're looking for and what we're looking at are considered abnormal, a consultation is warranted. At that point, it's up to the discretion of the consulting doctor as to whether or not co-management is feasible and the patient remain in care. Our Florida law and rule doesn't address specific requirements regarding abnormal liver function or findings, so care is at the discretion, like I just said, of the consulting physician and or the midwife if co-management is an option. And if co-management is an option, treatment varies greatly depending upon the diagnosed disorder. The end.